first gait pathology is a shortened step length. Shortened step length looks just like this. So you want to look out for short distance between the reference foot and opposite foot distance. And then this results in a greater gait cadence. And then this occurs during both the terminal stance and swing phase. Altered biomechanics include reduced hip extension in the late stance phase, reduced hip flexion during the swing phase, reduced plantar flexion during toe off, and then less activation of your hip flexors, glutes, and dorsiflexors, resulting in that shorter stride length, or step length, sorry. And then less ground reaction force during push-off, since you're not getting as much hip extension and plantar flexion. And then pathologies associated with a shortened step length include triceps surae injury, so you get less plantar flexion, hip flexor injury, less hip flexion, and then a knee joint patho when you don't want to bend your knee as much. Our next patho is the pelvic drop, which is similar to the Trendelenburg gait. So the pelvic drop during gait looks like your pelvis dropping to the opposite side of your stance leg, so dropping towards your swing leg. And then the trunk may also lean to the stance side as a compensatory movement. So during walking, it's like a drop, kind of like a hip hike. And then this is exactly what a Trendelenburg gait looks like. So you're getting that hip drop during the gait. And then this primarily occurs during the stance phase. So when you load your stance leg, your hip drops towards your swing side. And then this indicates a weak glute med. And then possibly more activation of your quadratus lumborum on your swing side, just to, in an attempt to level out your pelvis since your ipsilateral glute med is weak. And then this could also lead to more compressive forces on your stance limb, since you're really loading that side. And then pathologies associated with this is glute med weakness, superior glute nerve injury, which can lead to that glute med weakness, and then possible FAI, since you don't want to since you don't want to load your hip as much. Our next patho is a plantar flex ankle at initial contact. So what that looks like is this. So you want to look for your toes being pointed down during initial contact. Here's from the side angle. So I'm stepping forward, and then I'm not getting that dorsiflexion that you would want. You're getting more plantar flexion during the initial contact. And this occurs during your initial stance phase, so that initial contact right here. Biomechanics associated with this include reduced heel rocker. So under normal conditions, your heel rocker would look like with a heel strike and a slight rock. So with reduced heel rocker, with your reduced plantar flexion, that reduces your load transfer to the tibia. And then this also includes a higher loading of the forefoot, which puts more stress on your foot, ankle, and knee down the kinetic chain. Pathologies associated with this include gastroc spasticity or tightness. So you can't bring your foot into dorsiflexion because your gastrocs are pulling it into plantar flexion. Drop foot, such as a neuropathology. Hamstring injury, because you can't extend your hamstring as much and get that dorsiflexion. And then a knee joint pathology for the same reason, you can't extend as much and then get that dorsiflexion that you normally want. The next patho is inadequate plantar flexion at push-off. So that looks like this, kind of like your ankle is locked during push-off. So the propelling motion under normal conditions look like this, but with reduced plantar flexion, your ankle kind of stays in a neutral or slightly dorsiflex position. And this can result in a shorter step length since you're not propelling as far to off your push-off leg to your opposite leg. And this occurs during your late stance phase / early swing phase. And then biomechanics associated include reduced energy transfer up the kinetic chain to propel forward, It also implies reduced triceps surae activation since you're not since you're not plantar flexing as much, and then increased hip flexion or hip flexor activation to advance the leg up. And this also reduces ground reaction forces during push-off since you're not plantar flexing as much. And then pathologies associated with this include weak triceps surae, ankle sprain because of reduced mobility with that, and then a forefoot patho since you don't want to load that forefoot during push-off. Next patho is inadequate knee flexion during stance. So what that looks like is a straightened leg during your stance phase. On the side view. Under normal conditions, you want some knee flexion about 20 degrees during your stance phase. And then some biomechanics associated with this include reduced shock absorption, since you're not flexing your leg, so you're not getting that shock absorption that you would normally want. And then this results in greater loading of the knee, hip, and even your trunk as those forces travel up the kinetic chain. Pathologies associated with this include a quad pathology, such as weakness or tightness. So you're stuck in that extended position. Weakness implies you can't extend forcefully. Tightness implies that you can't get out of that extended position. And then knee joint pain, that implies that you don't want to move your knee into flexion, so you keep it extended during gait. Next patho is a forward trunk angle during gait. So what that looks like is you have your normal gait pattern, but then there's a forward flexion angle of your trunk. So that's what you want to look out for during gait. This occurs primarily in the stance phase, but it can be observed during the swing phase, so throughout the whole entire cycle. Biomechanics include increased hip flexion angle, which also may reduce knee extension. It also includes increased activation of your glutes to propel, since you're already in that flexed angle, so naturally your extension angle will be reduced. And then also increased activation of your rector spinae to stabilize your trunk. Since you're leaning forward, you want to stabilize it against gravity, and it could result in more activation of your rector spinae. And then this puts greater stress on your low back and your hip due to that angle. Pathologies associated with a forward trunk lean include low back patho, such as a herniated disc, and weak hip flexors and weak ankle plantar flexors. Next pathology is toe in and out. So toe in and out implies that your toes are pointed out or in during gait. So this primarily happens during your mid-stance phase. So when both feet are planted on the ground. And then, or right after push-off in the swing phase. So right after push-off, you see your toe in or toe out. So toe in, biomechanics, toe in implies that there is increased hip and tibial internal rotation, which then reduces your lateral stability. And this also increases loading on the lateral soft tissue, such as your peroneals, which may alter, and it also may alter your patellofemoral tracking. Toe out during gait implies that there's increased hip and tibial external rotation, and then reduced medial stability. There's increased loading on the medial and plantar structures. And then since that loading can pronate your foot, this can also result in increased valgus stress at the knee with toe out. Pathologies associated, so toe in pathologies include weak hip external rotators and abductors, so you're stuck in that internally rotated position, and then also a anteverted hip, that's a structural patho or observation, which results in that toe in posture. And then toe out, that implies weak hip internal rotators and adductors, so you're stuck in that externally rotated position. And then conversely to toe in, retroverted hip is applied for this one, another structural observation, which results in a toe out position. Next pathology is glute max gait. Glute max gait looks like this when you have an excessive backwards lean of the trunk during gait due to weak glute maximus. As mentioned, it occurs primarily in the early stance phase. So right at initial contact, you see that backwards lean of the trunk. Biomechanics associated with this is less hip flexion, so you're already in that backwards leaning, so you can't get as much hip flexion when you're accelerating forward. This also implies reduced activation of the glute max due to the nature of the pathology, so weak glute max. It can also imply increased activation of your hamstrings to compensate for your weak glute max. And then increased lumbar compression. Since you're already leaning back, your low back is getting increased loading, so you get compressive forces there. Pathologies include obviously glute max weakness, an inferior gluteal nerve injury, which can lead to that glute max weakness, and FAI, since you want to avoid that hip flexion angle, so you lean back to get less hip flexion. Next, the psoatic limp. So for psoatic limp, your affected leg will move during gait will move into flexion, external rotation, and adduction. So this is the best I could do. Let's try one more time. So your leg kind of stays in that position, stays flexed, stays external rotated and adducted due to a weak or injured iliopsoas on the affected side. And this is best observed during the swing phase, just like that. Biomechanics include decreased active hip flexion during swing phase, so it's kind of stuck in that hip flexion position. Your pelvis may also rotate to help clear your limb. So it would rotate posteriorly just to get your limb above the ground and forward. And this could also imply increased activation of your rec fem due to that iliopsoas weakness. So rec fem acting as hip flexor will compensate for that. And then your rec abdominis to assist with thigh elevation and propel that thigh up, and propel the thigh up via the pelvis. Patho associated include hip flexor strain, can't get the hip flexion as much, tendinopathy of your iliopsoas bursitis, internal snapping hip syndrome, leg Calvi's Perthes disease, and slip capital femoral epiphysis. Our last patho is drop foot, which is similar to the decreased plantar flexion during push-off, except drop foot will be observed throughout the entire gait. So drop foot, you get that decreased dorsiflexion during push-off. So you're stuck in that plantar flex position. You see it throughout the swing phase and at contact, so at your early stance phase. So this can be observed during both phases. So you kind of stay in that plantar flex position. Biomechanics associated include a reduced ankle dorsiflexion, increased hip and knee flexion just to get that clearance during your swing phase, increased forefoot landing or loading, just because you're landing on that forefoot, there's increased loading or forces going through your forefoot. And then reduce ground reaction force at push-off, since you're stuck in that plantar flex position already, so you can't propel as much. Pathos include common peroneal nerve injury, since this does innervate your tibia, so your ankle dorsiflexor, so that's why you're stuck in that plantar flex position, because you can't get into that dorsiflex position. Also multiple sclerosis, a nerve pathology, which can also impact your ankle dorsiflexors, so you're stuck in a plantar flex position. And then of course a tibialis anterior strain, again, making you stuck in a plantar flex position and leading to that drop foot posture.
The first gait pattern is the shortened stance time. It's seen in the stance phase. This is also known as a limp, and it comes from the injured side not wanting to make contact or keep contact with the ground. This can lead to an increased stance time for the opposite side and lead to increased injury risk on that side, but can be countered by using crutches. It looks like this. The next gait pattern is the asymmetrical arm swing. It is seen in both phases of gait. It's seen in people who have recently broken their clavicle or even dislocated their shoulder. It is where they don't swing one of their arms, and this can lead to potential spinal injuries from the abnormal rotation patterns in the spine. And it looks something like this. Next, we have flat foot at initial contact, and this is seen in the stance phase of gait. It comes from having weak dorsiflexors and sometimes is seen in people with pes planus feet. What this does is it increases the ground reaction forces in the affected foot, and it looks something like this. Next, we have the excessive knee flexion at initial contact. Again, this is seen in the stance phase of gait, and it usually comes from a hamstring strain or can sometimes be from swelling in the knee joint, which limits knee extension and range of motion. This not only feels very awkward, but also puts a lot of pressure on the knee joint. It looks like this. Next, we have the inadequate knee flexion during swing phase. Of course, this is seen during the swing phase of gait. It comes from an avoidance of stretching the hamstrings, either due to a strain and also the dragging of a foot because of not getting enough knee flexion to clear the ground. This is not only painful for the dragging foot, but also can be dangerous due to tripping and falling or potential injury of that leg. And it looks like this. Next is the inadequate hip extension at terminal stance. This is seen in the swing phase of gait, and it comes from a strain of the iliopsoas muscle, as well as the avoidance of stretching out that muscle. It can lead to a lengthening of the glutes and hamstrings, as well as a faster gait cadence and a shortened stride length. And it looks like this. Next is excessive foot pronation, and this happens in the stance phase, as it can cause genu valgum to the knee due to the eversion and slight plantar flexion of the foot. This could come from the affected side's leg being a bit longer, but it can cause medial calcaneal pain as well as medial patellofemoral pain. And this might be hard to see, but it's where my feet go in like that. This next one is the stiff knee or hip gait. It is seen in the swing phase, and it comes from potentially having arthritis or an avoidance to stretch the iliopsoas or the rectum. It can lead to shorter strides and increased circumduction in the stiff leg, which looks like this. Next we have the calcaneal gait, and it can be seen in the stance phase. This can delay toe off, and it can increase the amount of time and load on the affected side. It comes from weak plantar flexion and general ankle instability, and is where the foot, imagine this is the ground, goes like this and doesn't allow for toe off. It looks like this. Next up we have the short leg gait, and this can be seen in both the phases of gait. This can cause a hip dip towards the shorter side to let the longer side clear the ground, as well as toe walking and an increase in knee and hip flexion on the longer side. This usually comes about with structural leg length discrepancies rather than functional ones. And it looks like this. And lastly, we have the abductory gait. This can be seen in both of the phases, but is primarily seen right after the toe off. It's caused by the pelvis externally rotating out of sync with the tibia, so the tibia needs to catch up. And this is what's creating the twisting motion at the ankle. And it looks like this.